with this biochemistry session of the RDX series. We are going to discuss the 20 clinical questions that is very much anticipated for the INICET exam. With this biochemistry session of the RDX series, we are starting with is a disorder from the glycogen storage disease. A patient is presenting with severe hypoglycemia and is found to have some glycogen abnormalities. Plus, there is the abnormality that you can see is that there is a short outer chain, branches are there. Which enzyme is deficient? So the one thing is that is there is why this patient is developing hypoglycemia. Whenever we are in the fasting state, the glycogen is supposed to be cut down. And when we cut down the glycogen, ultimately in the liver, we have discussed that when we cut down the glycogen, that is referred as the glycogenolysis. In the glycogenolysis, when this process occurs in the liver, the last product that you are going to get, it is going to be glucose. Whereas if the glycogen is cut down in the muscles, the last product that we are going to get is actually glucose 6-phosphate. In the muscles, we can't convert the glucose 6-phosphate into glucose. The reason we are not able to convert the glucose 6-phosphate into glucose because the muscles don't have the enzyme glucose 6-phosphatase. So when we are in the fasting state, the glycogen is supposed to be cut down like this. Now, if during this cutting of the glycogen, there are several enzymes which are required. For example, during the cutting of the glycogen, we require the rate limiting step that is going to be there is the glycogen phosphorylase. Then the other enzymes that is required is debranching enzyme. And ultimately the phosphoglucomutase and the glucose 6-phosphatase, these are the enzymes which are required. And this is how the glycogenolysis is occurring. But when we are in the well-fed state, the extra glucose which we are eating, actually that converts into glycogen. The extra glucose molecules will be clubbed together and we make a huge molecule called as glycogen. That process is called as the glycogenesis. That is called as glycogenesis. So glucose converts into the glycogen when we are in the well-fed state. The glycogen looks like this. To make the glycogen, we have a protein in the beginning that is found in the liver called as glycogenin. On the glycogenin molecules, we are going to attach the extra glucose molecules like this. Initially, we are going to attach this extra glucose molecule in the linear sequence. And can you tell me that what is the direction of the bond when it is going to be a linear sequence? The direction of the bond that is going to be between these glucose molecules, this is going to be alpha 1,4 in the linear sequence. Because these glucose molecules are in the alpha glucose form. They are in the alpha glucose. So alpha glucose unites. The first carbon unites with the fourth carbon. And we make the linear sequence like this. Now, if once we have attached the enough glucose molecule, when we have attached the 11 glucose molecules like this, after that we can't attach more, then we have to make the branches. And this is how we make the branch. We attach the glucose molecule like this at the branching point, and this is going to be the direction is going to be alpha 1,6. And then again, we will have a linear sequence like this. Have the linear sequence like this. So to make this branch, actually, we require the branching enzyme. So during the this glycogen synthesis, we require the branching enzyme by which we make the branch and ultimately we make a huge molecule that is called as glycogen, and that will be there in our body. Now, if this branching enzyme is not there, if the branching enzyme is not there, the glycogen which will be made will not have these branches. There are some individuals who don't have this branching enzyme. Just imagine that if this branching enzyme is not there, means we can't make the branch. If you can't make the branch, means the glycogen will be only this much. We can't make the branch. The glycogen will be only having a linear sequence and there is no branches will be there. This particular disease, when the branching enzyme is not there, if there is deficiency of this, this is called as the Anderson disease. It's called as Anderson disease. That is due to deficiency of the branching enzyme. So this is what they are asking actually. What they are saying is the patient is developing severe fasting hypoglycemia. Whenever he is in the fasting state, he's developing hypoglycemia. And what we additionally found is that his glycogen is having shorter outer branches. Means the outer branches are not there actually. If the outer branches are not there, which enzyme is deficient? Because the branches are short, not there, means the branching enzyme deficiency is there. And the branching enzyme deficiency is referred as what? Anderson disease. And we use the mnemonic that is ABCD. ABCD stands for Anderson disease is due to deficiency of branching enzyme, and the Cori disease is due to deficiency of D branching enzyme. This is what we have learned. So Anderson is due to deficiency of the branching enzyme. The same thing is explained here in this diagram. Whatever is the extra glucose, we try to convert that into the glycogen molecule, and in that process we use the branching enzyme. If the branching enzyme is not there, the glycogen will not be made properly. The glycogen will be very less. If the glycogen is very less, whenever the person will be in the fasting state, when the person will be in the fasting state and will try to cut the glycogen will be depleted very early, and the patient might develop hypoglycemia. So the Anderson disease presents with hypoglycemia. In fact, the most of the glycogen storage disease, most means particularly the von Gierke disease, the Cori disease, Anderson disease. These are the ones that mainly presents with hypoglycemia. They mainly presents with the fasting hypoglycemia. Von Gierke, Cori, and Anderson. We will discuss them. There are some more MCQs are related to Cori. At that time, I will take care of the von Gierke disease also. So as of now, we have understood that the shorter outer branch means the branching enzyme is not there, so it is going to be the Anderson disease. Yes, very good. Now coming to the next one, a patient is presented with the fasting intolerance, means the patient is unable to tolerate the fasting state, and there is elevated lactate levels are there. Which enzyme deficiency can be there? Fasting intolerance is there. He can't tolerate the fasting. Is going into hypoglycemia, and he is having elevated lactate levels. See, what happens is we have discussed when the glucose metabolism happens, glucose converts into pyruvate, that is the glycolysis, and then the pyruvate have two possibilities that it may convert into lactic acid or it can convert into acetyl CoA. And that acetyl CoA will run the TCA cycle, and that gives you the energy. If you go on that side, means on the oxidative side, if you do the glycolysis, means pyruvate, then you go in the acetyl CoA, that is going to happen in the mitochondria, these oxidative process. If you do this entire thing, you are going to get a lot of energy. But if we go on the anaerobic side, means we are going to generate the lactic acid. The lactic acid is, if we do this process is referred as the anaerobic, this particular one, this side, this is referred as the anaerobic glycolysis. And anaerobic glycolysis will only give us 2 ATPs. The anaerobic glycolysis, the net energy gain is 2. Whereas if you do the aerobic oxidation, means this one, this side, it gives you 32 ATPs. So there is a significant difference in the number of ATP that is generated. If we are doing the anaerobic glycolysis, we are just going to generate in the anaerobic glycolysis, we are just going to generate 2, whereas aerobic is going to generate 32. Now, to do the aerobic glycolysis, to convert the pyruvate into acetyl CoA, we require the enzyme PDH complex, pyruvate dehydrogenase complex. And this enzyme is actually made up of 3 subunits, E1, E2, E3. Pyruvate dehydrogenase complex is made up of E1, E2, E3. Just imagine that if this enzyme is not working properly, the glucose is forced to go towards which side? The lactic acid side. So the lactic acid is going to increase. Yeah, that is very much evident that if this side is not working, if this enzyme is not there, the glucose will be forced to go towards this side and more lactic acid will be produced. That is fine. But why this patient is having fasting intolerance? We understand that if this enzyme is not there, the lactic acid will be more. But why fasting intolerance? Because if you do more anaerobic glycolysis, you are just going to get 2 ATPs. Let me give you one example. For example, my cell requires, let's say, 64 ATPs. My cell requires 64 ATP, just a random number. If I do the aerobic glycolysis, the one aerobic glycolysis will give me, means the aerobic oxidation gives me 32 ATP. So if I do the aerobic oxidation, just 2 glucose molecules will be enough. But if I want to generate the same amount of ATP via the anaerobic process, then I will be requiring the 32 molecules of glucose. Means there is going to be a significant consumption of the glucose will happen if we are doing anaerobic. And because this patient can only do the anaerobic, so the glucose consumption happens very fast. So the patient is unable to tolerate the fasting state. And that is why the answer to this question is going to be the pyruvate dehydrogenase deficiency. Pyruvate dehydrogenase deficiency, right? The another question that comes from the pyruvate dehydrogenase complex is, when it comes to pyruvate dehydrogenase complex, as I told you, it is made up of three subunits of the enzyme: E1, E2, E3. Sometimes they ask what are the names of these subunits. The E1 is also called as the pyruvate dehydrogenase. Actually, it's a misnomer. The better name is decarboxylase. E1 is decarboxylase. E2 is dihydrolipoyl transacetylase. And E3, it is going to be dihydrolipoyl dehydrogenase. This is the E1, E2, E3. The E1, can you tell me what is the coenzyme for E1, what is the coenzyme for E2, and what is the coenzyme for E3? Yes, E1, the coenzyme is vitamin B1. This is how we have remembered. E1, the coenzyme is B1. E3, the coenzyme is B3. E3 is B3, B2. So E1 is B1, E3 is B3, B2, and E2 is B5. B5 and lipomide. It's very good. Right. So sometimes they might ask you that what are the subunits are there of pyruvate dehydrogenase complex? It's E1, E2, E3, and the names are this: pyruvate dehydrogenase, E2 is dihydrolipoyl transacetylase, and E3 is dihydrolipoyl dehydrogenase. Dehydrogenase. Yes, very good. So the summary of the take home message from this question is going to be, it is like this: this patient is having fasting intolerance, is unable to tolerate the fasting, the lactic acid is more, which enzyme is deficit? Is going to be pyruvate dehydrogenase. Now if we talk about the other enzymes, what are the other enzymes that are written here? See, the pyruvate carboxylase, it is used during gluconeogenesis. Is used in the gluconeogenesis, and that is going to be used in the well-fed state. When the patient is in the well-fed state, then we do when we are going to do the gluconeogenesis, at that time the pyruvate carboxylase is required. Phosphofructokinase 1, if it is for PFK1, that is the rate limiting step of glycolysis. And the pyruvate kinase, it is basically the last enzyme in the glycolysis, the 10th enzyme. Can you answer me, if there is a deficiency of this enzyme, it leads to what? That is the second most common cause of what? Pyruvate kinase deficiency leads to what? Can you tell me that? Pyruvate kinase deficiency leads to what? Pyruvate kinase deficiency leads to hemolytic anemia. Second most common cause of hemolytic anemia, pyruvate kinase deficiency, because pyruvate kinase is the enzyme of the glycolysis which produces the ATP. And RBCs are purely dependent on the glycolysis for the energy purpose, because the only pathway which occurs in the cytoplasm and can generate the energy, it is going to be the glycolysis. And if the glycolysis is not happening because this enzyme is not there, then the glycolysis will not happen, the RBC can't survive and will lead to hemolysis, and that is called as the pyruvate kinase deficiency, leading to the hemolytic anemias. Coming to the next one, that is it's an easy one. It's an easy one. In a patient with maple syrup urine disease, which amino acid are found in excess in the urine? We know that maple syrup urine disease is a disease of branch chain amino acids. It's a disease of branch chain amino acids. The branch chain amino acid that we have remembered a mnemonic. To have a branch relationship, the person has to be live-hearted. Live-hearted. So branch chain amino acid, live. Leucine, isoleucine, and valine. Leucine, isoleucine, and valine. Leucine, isoleucine, and valine. Now, when they are metabolized, to metabolize the leucine, isoleucine, valine, we have one common enzyme, and that is called as the branch chain alpha keto acid dehydrogenase. There is a common enzyme, branch chain alpha keto acid dehydrogenase. If what, and then ultimately they are going to make their metabolites. The leucine, the ultimate metabolite of the leucine, because it's a ketogenic amino acid, so leucine is going to make the ketone body. Whereas the isoleucine and valine, they are the glucogenic, so they can be converted into glucose ultimately. So now what happens is, if this enzyme is not there, if the branch in alpha keto acid dehydrogenase, it's not there, these molecules will not metabolize and the intermediates are going to accumulate. These amino acids are going to increase, the intermediates are going to increase. And that will start coming in the urine also. And they will start coming, these intermediates will start coming in the urine and the body secretions. So the body secretions will have the smell like burnt sugar. Yes, there is going to be burnt sugar like smell in the body secretions. That is called as the maple syrup urine disease. So it was a simple question that in a patient with maple syrup urine disease, which amino acid will be found in the excess? It's going to be the branch chain amino acid, leucine, isoleucine, valine. But if I want to ask you a difficult question, it may be like this. The maple syrup urine disease, it is of three types. Maple syrup urine disease, when it comes to types 1, 2, and 3. When it comes to the maple syrup urine disease type 1, actually, the enzyme which is leading to maple syrup urine disease, it is okay, let's write down like this, the branch chain alpha keto acid dehydrogenase. It is made up of actually three subunits of enzyme E1, E2, E3. The name of the E1 is decarboxylase. The E2 is the dihydrolipoid transacylase, and E3 is dihydrolipoid dehydrogenase. These are the three ones. So if there is a deficiency of the E1 component of this enzyme, this is called as the type 1 maple syrup urine disease. If the deficiency of E2, it's called as type 2. If there is deficiency of E3, it's called as type 3. So we have three types of maple syrup urine disease. Can you tell me that which is the most common out of these three? Which is the most common? 1, 2, 3. Which is most common? Yes, it is going to be the most common is type 1. The most common is type 1. So sometimes they ask the question like this. In maple syrup urine disease, it is due to deficiency of branch chain alpha keto acid dehydrogenase. Which main reaction is defective? And since the most common is E1 deficiency, and E1 is doing what? Decarboxylation. So the main reaction that is defective is actually the oxidative decarboxylation. So in the maple syrup urine disease, if they have not mentioned any type or something like that, and they just say which is the main reaction is defective, it is going to be the oxidative decarboxylation. Oxidative decarboxylation, right? Okay, this is the maple syrup urine disease. Can you tell me there is one more disease that is related to branch in amino acid? One is maple syrup, there is one more. That is isovaleric acidemia. Isovaleric acidemia, also a branch in amino acid disorder. We know what are the branch in amino acid we have: leucine, isoleucine, valine. Can you tell me isovaleric acidemia is a disease of which branch in amino acid? Is it a disease of isoleucine? Is it a disease of valine? Or is it a disease of both? Or it's a disease of none? Yes, it's a disease of none of them. Isovaleric acidemia is a disease of leucine metabolism. It's a leucine metabolism defect. Yes, very good, Abhishek. It's a leucine metabolism defect. It's a leucine metabolism defect, and it is isovaleric acidemia. It is due to deficiency of the isovaleryl dehydrogenase. Plus, the clinical feature that we are going to have is the sweaty feet smell, the sweaty feet odor of the body secretions, such as the urine, uh, the stool, will have the sweaty feet smell. That is called as the leucine metabolism disorder. That is isovaleryl dehydrogenase, isovaleric acidemia. That these are the points to remember when it comes to the branch chain amino acids. We have, yes, rightly said, we can do the ferric chloride test also for the, but it's not specific. Ferric chloride test can be done. And ferric chloride test, can you tell me the ferric chloride test can also be done for what other disease apart from maple syrup urine disease? Yes, ferric chloride test also done for, it can be also positive for phenylketonuria. It is also positive for L-captonuria. So it's not a very specific one. Ferric chloride can be positive for maple syrup, phenylketone, or alkaptonuria. The next one. The next one is a patient is diagnosed with Lesch-Nyhan syndrome. It's again simple, straightforward. Actually, it's more of a one-liner that is there. The Lesch-Nyhan syndrome, the enzyme deficiency that is there is going to be the HGPRTS. The Lesch-Nyhan syndrome is deficiency of HGPRTS. Now, what are the points to be remembered and where this enzyme comes? HGPRTS. Can you tell me the HGPRTS enzyme belongs to which pathway? It belongs to which pathway? It belongs to the when we do the purine synthesis by the salvage mechanism, not the de novo, but the salvage mechanism. We are making the purine synthesis. This enzyme comes. Let's understand where is this purine salvage pathway that we are having and where how this Lesch-Nyhan is coming. The question was straightforward, but let's understand some points regarding the HGPRTS, where it is coming, how, what are the other questions that can be formed around this. When it comes to HGPRTS, it will be like this. See, we are having the two main purines we have, A and G. And if I told you, if I ask you that, what are the main purine nucleotides we have? It is adenosine monophosphate and guanosine monophosphate. These are the main main purine nucleotides. Actually, these purine nucleotides, they are made from one common purine nucleotide that was adenosine monophosphate. The IMP actually converts into AMP and GMP. So overall, we are having three purine nucleotides with us: AMP, IMP, and GMP. When the cell death happens, the AMP, GMP, IMP, they will be destroyed. That is called as the purine catabolism. For example, if I break the adenosine monophosphate, we are going to generate adenosine. You can break it further and you will make adenine. In the same way, guanosine monophosphate, when you break, you get guanosine. You break it further, you are going to get guanine. Now, you can break it further also. Means if I want to break it further, the adenosine can convert into inosine with the help of enzyme adenosine deaminase. And this inosine will convert into hypoxanthine, then converts into xanthine, then ultimately into uric acid. In the same way, this guanine can convert into xanthine and xanthine can convert into uric acid. So this is how we destroy actually when a cell death happens. This is how we destroy the purines. The uric acid could have been converted into allantoin with the help of enzyme uricase. But in humans, this enzyme is physiologically not there. So we can't do this reaction. So the last product in the purine catabolism that we generate is the uric acid. But when it comes to the salvage, what is the meaning of salvage is when we are doing the destruction of the purine, at that time we realize in between that, okay, no, we want these purines back. We want to reuse them. So for example, I was cutting the purine, I got adenine, but now I want to make the purine nucleotide again. Then what we can do is we will attach with the PRPP and we will use the enzyme HGPRTS and we can make actually the AMP back and that can be reused to make the DNA and RNA. In the same way, the guanine with the help of HGPRTS can be converted back into GMP and can be reused. So we can reuse the AMP and GMP, and this pathway is called a salvage pathway, and the HGPRTS comes here. Now you answer me one question. It's very clearly, if the HGPRTS is not there, the salvage pathway will not occur. The salvage will not occur. If the salvage will not occur, means all the purines which are going to come into catabolism pathway, they have to go into catabolism only. And what is the last product of the catabolism? What is the last product of the catabolism? It is the uric acid. It's the uric acid. That is why if the HGPRT is not there, the salvage cannot happen. So everything has to come down, narrow down to uric acid. And this disease is called as Lesch-Nyhan syndrome. That is why in the Lesch-Nyhan syndrome, we have excess amount of uric acid. Excess amount of uric acid because the salvage is not happening. Now, here we understood that when it comes to HGPRTS deficiency, the deficiency is called as Lesch-Nyhan syndrome. It's going to be X-linked recessive disorder. It's an X-linked recessive disorder. One thing we have understood, there is going to be increase in the uric acid, and since there is increase in the uric acid, so there is a risk of gout. Secondly, there is one more thing that happens. This Lesch-Nyhan syndrome, boy, it will have the feature of self-mutilation. There is a chance of self-mutilation, means this will eat out its own organs. The child is going to have profound mental retardation and he is going to eat out its own finger, toes, he's going to eat out them. There's going to be self-mutilation. This is called as Lesch-Nyhan syndrome. It's an X-linked recessive disorder. Now, can you tell me that if there is a partial deficiency, or I can say mild deficiency of HGPRTS, what is the name of that disease? If there is a mild deficiency of HGPRTS, that is called as what? Pure deficiency, Leishnian. Mild deficiency is called as what? It is called as the Cayley-Sackmiller syndrome. Cayley-Sackmiller syndrome. It is going to be very similar to Leishnian, but it's going to be milder version because there is a mild deficiency of HGPRTS. So when it comes to the purine catabolism or the salvage pathway, there are two important enzymes. One is the HGPRTS, and second important enzyme is this adenosine deaminase. If this adenosine deaminase is not there, then again the purine catabolism doesn't happen properly, and the salvage also may not happen. So in that case, if the deficiency of this adenosine deaminase occurs, if there is deficiency of adenosine deaminase is there, that is called as the severe combined immunodeficiency. If the adenosine deaminase is not there, why it is called as combined immunodeficiency is combined means basically the T cell and B cell both are involved. T and B both are involved, so it's called as combined deficiency. Combined deficiency. Yes, rightly said, Danuj. It's combined immunodeficiency. Coming to the next question. A patient presents with a peripheral neuropathy, angiokeratomas, and hypohidrosis. Which enzyme deficiency is there? The most important characteristic word that you should have picked in this, what is the name of that main hallmark feature that you can see in this MCQ? It is the angiokeratomas. It's very good. The angiokeratomas. This is the main keyword. If the angiokeratoma and peripheral neuropathy is written, they are talking about which disease? They are talking about the Fabry disease. Fabry disease. In the Fabry disease, basically, when we want to metabolize the galactocerebrocytes, here it is written, see here, Fabry disease is an X-linked recessive disorder. When we want to metabolize the galactocerebrocyte, we require an enzyme called as alpha-galactocerebrosidase. If this enzyme is not there, if there is deficiency of this enzyme, then this reaction will not happen. And the galactocerebrocytes are going to accumulate. And they will present as the tingling sensation, means the peripheral neuropathy will be there. And there's going to be the angiokeratomas. There's going to be angiokeratomas, and that is the most important hallmark for this. The small tumors containing the blood vessels, called as the excess amount of the blood, the keratin is there, it's called as angiokeratomas, and the patient will have diarrhea. This is called as the Fabry disease. It is a type of sphingolipidosis. So here they are asking that because this angiokeratoma word was there, so it's a Fabry disease, and Fabry disease, it is due to deficiency of the alpha-galactocerebrosidase. Alpha-galactocerebrosidase. So the answer is going to be the A1, so alpha-galactocerebrosidase. Then in the Fabry disease, okay, here there are two options are written: alpha-galactocerebrosidase 1, A and B. Fabry is basically deficiency of alpha-galactocerebrosidase A. There is one similar disease that is there is when the galactocerebrocytes are metabolized. When the galactocerebrocytes are metabolized, we are using the enzyme, the galactocerebrosidase. We have the galactocerebrosidase alpha and beta. If there is deficiency of alpha, Fabry. We remember like this: alpha deficiency, Fabry. If there is deficiency of beta, beta is Krabbe. So you can remember like this: Bakra. Beta is Krabbe, Bakra, alpha, Fabry. Now, yes, it was the A and B options were a little confusing actually, and that was creating actually the problem, right? So alpha galactosidase A, it's going to be the Fabry disease, and B, if they are talking about basically beta. The B word is actually referred for the beta word, so that is going towards the Krabbe part. But since the A word was there, so it's alpha galactosidase A deficiency. Now the next one is a newborn is coming to us. He's having hyperammonia and he's having increased amount of orotic acid in the urine. Which enzyme deficiency is there? What do you say? Which enzyme deficiency is there? The hyperammonia is there and orotic acid is more in the urine. See, what we have discussed in the urea cycle is how the urea cycle works. The ammonia and carbon dioxide meets together and they do total 5 reactions, and ultimately we generate the urea. This is what we have discussed in the urea cycle, and that is happening in the liver. Then this urea comes in the blood. When the urea comes in the blood, that is called as the blood urea nitrogen. Blood urea nitrogen, and this urea then goes to the kidney and it will be filtered out and will go out of the body in the urine. Now there are several enzymes are there. The first enzyme that is there in the urea cycle, it is going to be the CPS1, carbamyl phosphate synthase 1. Then we have the ornithine transcarbamylase. Then we have the different enzymes are there. So if by any chance, if the urea cycle is not working, there are two things which are very much fixed. If there is deficiency of any enzyme out of these five, this urea cycle will not work. So ultimately, what is going to happen? The ammonia is going to increase and the urea is going to decrease. And if the urea is going to decrease, the burn is going to decrease. So in all the cases, whenever the urea cycle is not happening, the ammonia is going to increase and the burn is going to decrease. Now, if there is deficiency of CPS1 is leading to the problem that is called as hyperammonia type 1. If there is deficiency of OTC, it's called as hyperammonia type 2. So how we differentiate whether we are having hyperammonia type 1 or type 2? In the hyperammonia type 1 and type 2, the differentiating feature is going to be the orotic acid. If the orotic acid is coming in the urine, it is going to be the hyperammonia type 2. It is type 2. Let's see here how it is going to happen. For example, these are the 5 steps that is there. If this enzyme is not there, this reaction will not happen. This reaction will not happen, but the carbamyl phosphate is there. This carbamyl phosphate, because it can't convert into citrulline, it converts into another molecule that is called as orotic acid. And that will come in the urine. So if the hyperammonia with orotic acid urea is written, then we have to think of hyperammonia type 2. Now, let's understand some more here, and then we will see the answer also. For example, this this urea cycle, the ornithine which is produced in the last step, this ornithine comes back with the help of ornithine transporter. If the ornithine transporter is not working, the ornithine can't go inside, and again the reaction cannot happen. This particular disease is called as triple S syndrome. There's going to be hyperammonia because the ammonia can't convert into urea. There's going to be hyperammonia. Because the ornithine can't go inside, so the ornithine will not be utilized. So there's going to be hyperornithinemia. So there's going to be hyperammonia, hyperornithinemia. But what happens is, because this enzyme is there, the ornithine transcarbamylase is there. In that case, this carbamyl phosphate, because it can't convert into citrulline, because the ornithine is not going inside, so the carbamyl phosphate can't convert into citrulline, but it converts into a special molecule that is called as homocitrulline. So in a triple S syndrome, because ornithine transport is not working, the ammonia increases, the homocitrulline is there, and ornithine is there. So it's called as hyperammonia, homocitrullinemia, and hyperornithinemia. Let me summarize the data for you. Now, this will solve your most of the MCQ. Whenever there is increase in the ammonia and decrease in the urea, that is called as hyperammonia, means there is some problem in the urea cycle. If they say orotic acid is increased or uracil is increased, and that is leading to macrocytic anemia also, they are talking about the hyperammonia type 2. So this is the buzzword for us. In the urea cycle, if they say increased amount of orotic acid, uracil or macrocytic anemia, it's type 2. Then if they say, if there is triple hyperammonia is there, hyperornithinemia is there, homocitrullinemia is there, then they are talking about triple S syndrome. Sometimes they want to hide you these things. So what they do is, we know that whenever the ornithine is more, it is going to accumulate in the retina and it is going to damage the retina. That is called as gyrate atrophy. So if they say there is a hyperammonia with gyrate atrophy, they want to tell you about triple S syndrome. They are pointing towards the triple S syndrome. Then the next one is, if the ammonia is more and the citrulline is also more, it is going to be easy and straightforward. Look at this flow chart. Now you answer this question. I am removing the other data for you. Let's remove the other data. For example, If this enzyme is not there, arginosuccinate synthetase is not there, the citrulline can't convert, right? And the citrulline is going to increase. And this disease is called as citrullinemia. So if there is more citrulline, it's citrullinemia. That's not very important. What is very important? What is very important is this next one. Now you will answer the question. If this enzyme is not there, this molecule is going to increase the arginosuccinate, and that is called as arginosuccinate amia. Arginosuccinate amia. If the arginosuccinate amia occurs, arginosuccinate is bad for hair. There's going to be problem with the hairs. So if they say hyperammonia with hair problems, they are talking about arginosuccinate amia. So these are the buzzwords for us. Let's recall the buzzwords, how we are going to make the diagnosis. If they say hyperammonia with orotic acid increased or increase in the uracil, that is type 2. If they say hyperammonia with gyrate atrophy, that is triple S syndrome. If they say hyperammonia with there is a problem in the hairs, they are talking about arginosuccinate urea or the arginosuccinate anemia. So these are the three important buzzwords to be remembered to make the diagnosis of the different types of hyperammonia. Right? Okay. Let's move forward then. A patient is treated with the statins. Which enzyme is specifically inhibited by the statins, the atorvastatin, the rosuvastatin? They are going to inhibit the which drug? Yes, they are going to inhibit which enzyme? That is a rate limiting enzyme for the cholesterol synthesis. They inhibit the rate limiting enzyme of cholesterol synthesis. That is going to be the HMG-CoA reductase. HMG-CoA reductase. They are going to inhibit the HMG-CoA reductase. If I just show you that how the cholesterol synthesis is happening, look at this cholesterol synthesis pathway. In the cholesterol synthesis that occurs in the endoplasmic reticulum and the cytoplasm. Because cholesterol is a derived lipid, we are going to derive it from triglycerides. The triglycerides will be broken down. We are going to get the 3 fatty acid and glycerol. The fatty acid will undergo beta oxidation. We are going to generate the acetyl-CoA. Then the further reactions occurs. And ultimately, we are going to generate the cholesterol. What they ask actually in this pathway is only 3 to 4 questions. The first, the rate limiting enzyme of cholesterol synthesis, HMG-CoA reductase. How to inhibit this enzyme if we are having hypercholesterolemia? By giving the statin. The second thing that they ask is that what are the sequence of intermediates that we have? When it comes to the sequence of intermediates that is there, the mnemonic that we are going to use is MISC, miscellaneous. Mevalonate, isoprenoid, sequalin, and cholesterol. This is the sequence of intermediate is there. There is one more that is there is lenostrol. But if you just remember the miscellaneous, because sometimes they ask this question, what is the sequence of intermediate that is there in the cholesterol synthesis pathway? It is going to be mevalonate, isoprenoid, sequalin, and cholesterol. Then what is the use of this cholesterol that we are making? This cholesterol, it is going to be used to make the bile acids, the vitamin D, and the steroid hormone. The steroid hormone. Can you tell me that when we are going to make the bile acid, what is the rate limiting enzyme for bile acid synthesis? Can you tell me what is the rate limiting enzyme for bile acid synthesis? Is it 7 alpha hydroxylase or 1 alpha hydroxylase? To make the bile acid, the rate limiting enzyme is going to be 7 alpha hydroxylase. 7 alpha hydroxylase. But when you are making the vitamin D, what is the rate limiting enzyme for vitamin D synthesis? It is going to be 1 alpha hydroxylase. 1 alpha hydroxylase. Right? So this is how the cholesterol can convert into bile acid, can convert into vitamin D with the help of the hydroxylase enzyme 7 alpha and 1 alpha. One very important question from bile acid. They ask the question, we have the primary bile acid, we have the secondary bile acid. They say that which of the following is not primary or which of the following is secondary bile acid. What is the same simple mnemonic? The simple mnemonic is secondary bile acid is LSD. LSD means the secondary bile acids are the lithocholic acid and deoxycholic acid. So we will remember like this, secondary will start with the letter L or letter D. Secondary is lithocholic or deoxycholic. The remaining everything is going to be primary, right? The taurocholic, glycotaurocholic. There are many ones. We have discussed them in detail otherwise, but as of now, just remember the secondary. What are the secondary? LSD, L and D. That is secondary, and your question of primary and secondary will never go wrong. Okay, very good. So it was a simple question that which drug is going to inhibit the cholesterol synthesis is going to be the HMG-CoA reductase inhibitor, that is going to be statins. A patient is presented with the progressive hepatosplenomegaly. there is anemia, and on the bone marrow biopsy, there was lipid-laden macrophages were there. They were resembling like a crumbled tissue paper appearance. The macrophages, the cytoplasm of the macrophages was looking like a crumbled tissue paper appearance, and that was enough big hint that was there, right? The diagnosis for this disease is going to be the Gaucher disease. In the Gaucher disease, they are going to say that there is a child, let's say 8-year-old, is going to have decrease in the hemoglobin. There's going to be anemia. There's going to be hepatosplenomegaly, and there's going to be the crumbled tissue paper appearance of the cytoplasm in the bone marrow examination of the lipid. Basically, Gaucher disease, why it happens actually? Look at this flow chart. Normally, the glucocerebrocytes are metabolized by the beta glucocerebrosidase. If this enzyme is not there, the glucocerebrocyte will not metabolize, they will accumulate. And they will accumulate in the different places. They can accumulate in the liver, spleen, in the bone marrow. If they will accumulate in the liver, spleen, there's going to be hepatosplenomegaly. They will accumulate in the bone. So there's going to be the bone marrow will be damaged. And if the bone marrow will be damaged, so there can be anemia. There's going to be decrease in the WBC. So the infections will be there. The bleeding disorders, platelets will be less, and they are going to damage the bone also. There's going to be bone deformity that is called as the Erlenmeyer flask deformity. Here you can see Erlenmeyer flask deformity. Look at the femur bone. Look at the femur bone is of this child. It's called as the Erlenmeyer flask deformity. That is going to be there. And these are the lipid-laden macrophages that you can see looking like a crumbled tissue paper appearance of the cytoplasm. Crumbled tissue paper. Yes, it was again important question, this Gaucher disease, because this is the most common sphingolipidosis that we have. This is the most common sphingolipidosis. There are many diseases, Fabry, Krabbe, Gaucher, T6, and out of them, and in fact itself is its MCQ. What is the most common sphingolipidosis? It's going to be Gaucher. The most common sphingolipidosis. There is one more question, which is the X-linked sphingolipidosis. The X-linked sphingolipidosis, it is going to be Fabry. X-linked is going to be Fabry. Then we have discussed that all sphingolipidosis have hepatosplenomegaly. In everyone, we have hepatosplenomegaly, except in which disease we don't have. It is going to be Fabry, Krabbe, and Tay-6. Here we don't have the hepatosplenomegaly. Can you tell me that the Tay-6 is due to deficiency of which enzyme? T6 is due to deficiency of which enzyme? Can you tell me, guys? T6 is due to deficiency of which enzyme? T6 is due to deficiency of hexosaminidase A. Hexosaminidase A. And if there is deficiency of A and B both, then it is called as what? Send-off. That is called as send-off. So here you can see the hepatosplenomegaly, anemia, the bone marrow biopsy, lipid-laden macrophages, crumbled tissue. The diagnosis was Gaucher, and it is due to deficiency of the beta glucocerebrosidase. So the answer is going to be the glucocerebrosidase. The better answer would have been beta glucocerebrosidase. Right? Okay. Let's move to the next one. A 5-year-old child is presented with hepatomegaly, fasting hypoglycemia, and diagnosed with glycogen storage disease. In the beginning itself, I told you, glycogen storage disease leading to hypoglycemia, there are 3 things that should come in your mind. One, von Gierke disease. Second, Cori disease. And the third, we have already discussed, that was Anderson disease. In all these diseases, we are going to have the fasting, there's going to be hypoglycemia that will be there. What additionally they have found is, they have found that there is glycogen with abnormal structure due to defective debranching enzyme. Not they have written the debranching enzyme, they have written the defective debranching of the glycogen. But the debranching is not happening. Debranching is not happening means debranching enzyme is not there. And debranching enzyme is not there. We have the mnemonic ABCD. If the debranching enzyme is not there, it is due to which disease? It is seen in which disease? Cori disease. And Cori disease, does it leads to hypoglycemia? Yes, it leads to hypoglycemia. So they have said that the glycogen storage disease leading to hypoglycemia, these are the 3, and they said that the debranching enzyme is having the problem. There's debranching problem. Debranching problem means it's a Cori disease. It's a Cori disease. It's a simple one, right? Now, let's talk about the von Gierke disease also, because that is the most common glycogen storage disease. That is the type 1, and that is the most common. The answer here was the von Gierke. That is the answer here was the Cori. That was the type 3 glycogen storage disease. But the most common, the glycogen storage disease that we have in the children is the von Gierke. Von Gierke is due to deficiency of glucose 6 phosphatase. Glucose 6 phosphatase. And this enzyme is actually only found in the liver. This enzyme is physiologically absent in muscle. So if there is a deficiency of this enzyme, that is only going to affect the liver. It's not going to affect muscle, because this enzyme is not there at all muscles. It's not there in the muscle. Now, if the glucose 6 phosphatase enzyme deficiency is there, if the glucose 6 phosphatase is there, the child is going to develop severe hypoglycemia. Severe hypoglycemia. And it is also seen that there is going to be increase in the uric acid. There's going to be increase in the lipid in these patients. So if you see this combination, in which glycogen storage disease we have severe hypoglycemia, hyperuricemia, and hyperlipidemia, they are talking about von Gierke. Von Gierke. Right? Very good. Let's come to the next one. A neonate is presenting with hypotonia, means there is some problem with the muscle. There's decrease in the tone in the muscle. Cardiomegaly. The problem with the cardiac muscles also, the muscle biopsy reveals glycogens in the lysosome. There is some glycogens are there inside the lysosome. There is only one reaction which occurs in the lysosome related to glycogen. Means what? For example, okay, let's look at here. Here is the muscle. Here's the muscle, and here is the glycogen molecule. Normally, the glycogenolysis occurs in the cytoplasm, and we do the breakdown. We do the breakdown, and we are going to get the glucose 6 phosphate, and that glucose 6 phosphate will be further used for the energy purpose. That is normal. Some amount of glycogen also goes inside the lysosome and metabolized inside the lysosome with the help of enzyme acid maltase, and that will make the glucose. But now, if by chance this enzyme is not there, if there is deficiency of acid maltase, the glycogen will come inside the lysosome, but it will not be metabolized. And the glycogen is going to accumulate in the lysosome of the muscle. And this is what the MCQ is saying, that muscle biopsy is showing inside the lysosome there is glycogen. Means this enzyme is not there, acid maltase. And if the acid maltase is not there, this is called as the Pompe disease. Pompe disease. And that is going to primarily affect the muscles. There is going to be proximal myopathy. There is going to be the cardiomyopathy. The respiratory muscles, the diaphragm will have the problem. There is going to be macroglossia. These are the problems which are related to the muscles that we are going to see. So the glycogen storage disease, which are primarily affecting the muscles, are mainly two, Pompe and McArdle. And it is going to be the Pompe disease. It's going to be the Pompe disease. And what is the treatment of this? The problem is this enzyme is not there in the muscle. So we are going to do the enzyme replacement, and that is called as myozyme. This itself is an MCQ. What is the treatment of Pompe? Myozymes. We are going to give the myozymes. So the answer is going to be the Pompe disease, and Pompe disease is due to deficiency of acid maltase, which is also called as the alpha-1,4 glucosidase. Alpha-1,4 glucosidase. That is the deficiency is there. Then, can you answer me one question that there is one glycogen storage disease, which is also a lysosomal storage disease. Normally, the glycogen storage are von Gierke, Pompe, Anderson. These are the glycogen. What are the lysosomal storage disease we have? The lysosomal is Hunter, Hurler, right? Sanfilippo. They are there. There is one disease which is related to glycogen as well as related to lysosome. That is glycogen storage disease as well as lysosomal storage disease. Yes, that is the Pompe, because that is related with glycogen as well as lysosome. So it's a glycogen storage disease as well as lysosomal storage disease, the Pompe disease. Very good. Very good, Anj. So we are halfway down. Coming to the next one. A patient is with the history of alcohol is presenting to us. He's having confusion, ataxia, and ophthalmoplegia. There's a paralysis of the eye muscles. His imbalance is there, and he's having global confusion, right? It's a classical triad of Wernicke's encephalopathy. Wernicke's encephalopathy is there. It's a classical triad. So Wernicke's encephalopathy. Wernicke's encephalopathy, it is seen in the, basically mainly seen in the alcoholics, those who are having vitamin B1 deficiency. if there is an alcoholic having vitamin B1 deficiency, that will lead to damage to the mammary body and the dorsomedial nucleus of the thalamus. The mammary body and dorsomedial nucleus will be damaged, and the patient will develop this classical triad that is referred as GOA: global confusion, ophthalmoplegia, and ataxia. So, which coenzyme is actually they are asking that which deficiency is there, which is basically is a coenzyme that is going to be the vitamin B1. And what is the treatment that is supposed to be given is actually we have to give vitamin B1 as well as glucose both. But can you answer me what you are going to give first? Will give B1 or you will going to give dextrose? What you are going to give first in the treatment? Yes, first we have to give vitamin B1, and that will be followed by dextrose. Because if we give dextrose, that is going to further deteriorate the patient. First, we are going to give B1, then we'll give the dextrose. So, which coenzyme is deficient? It is thiamine, that is vitamin B1, right? And if we are not going to treat this patient, if we don't treat this patient, Vernix, what is the complication that it is going to develop? The complication of Vernix, yes, rightly said, it's going to be Korsakoff. There's going to be Korsakoff psychosis, and what you are going to see there? Confabulations. Confabulations will be there, right? Okay. So this is what is happening here. Vitamin B1 deficiency, it is associated with the polished rice also. Seen in the chronic alcoholics, there is going to damage to the mammary body, leading to the global confusion, ophthalmoplegia, ataxia. Diagnosis Vernix. First, you give vitamin B1 followed by dextro. If not, it will convert into Korsakoff. The next one. A 35-year-old male is presenting to us with the muscle cramps. The muscle cramps are there, and he's having the myoglobinuria. The myoglobin is coming in the urine. The muscle cramps after intense exercise, the myoglobin is coming in the urine. His blood lactate level does not rise after exercise, does not increases. Which enzyme is most likely responsible for his symptoms? So basically, one simple thing we have understood is whenever he's doing exercise, he's developing some problem. He's developing muscle cramps, and the myoglobin starts coming in the urine. Means he's unable to tolerate the exertion. Whenever he's doing exertion, the muscles are getting damaged. The myoglobin, which is a protein of muscle, it is coming out. It is coming in the urine. That is the myoglobinuria. So they are asking that what is the diagnosis? Which enzyme deficiency is there? Look at here. We have discussed there is an 18-year-old boy, Rakesh. He went to the gym for the first time in his life. Do you remember? The physical exertion. Whenever we do some exertion, or muscles requires energy. How the muscle gets energy? Yes, they are going to break down the glycogen. We are going to break down the glycogen. We break down the glycogen with the help of enzyme glycogen phosphorylase. The product we are going to get glucose 1 phosphate, glucose 6 phosphate, glycolysis, and ultimately ATPs. This is how we get the energy. But by chance, if this glycogen phosphorylase is not there in the muscles, if it is not there in the muscle, it will not cut down. The 1 phosphate, 6 phosphate will be less, and ultimately the energy will be depleted. So when this patient will do the exertion, see, you and me, we don't have the problem with the exertion because we can burn the glycogen in the muscle, we can generate the energy. But if the glycogen phosphorylase is not there, the reaction will not happen. The ATPs will be depleted in several minutes, and then the myocytes will rupture. When the myocytes rupture, the myoglobin comes out, and this myoglobin will go all the way to the kidney. It will be filtered, and it can come in the urine. So we will have a dark color urine. We'll have a dark color urine, right? And that is basically, it is the myoglobinuria. So whenever you see a patient, is whenever he's doing physical exertion, followed by muscle pain, followed by dark color urine, they are talking about the McArdle's disease. And that is due to the deficiency of muscle glycogen phosphorylase. The diagnosis was McArdle's. That is a type 5 glycogen storage disease. Now let's answer me few more questions from the dark urine. If I say there is a patient, he's having abdominal pain. Now you will answer Chandan, Anuj. Abdominal pain is there. There's increase in the blood pressure, and the patient is having dark urine. Can you tell me what is the answer? Abdominal pain, increase in the blood pressure, dark urine. What is the answer? Severe abdominal pain. Yes, it is going to be acute intermittent porphyria. acute intermittent porphyria. We have discussed in the heme metabolism. So there is going to be dark urine. They will say dark urine, and if you put in the sunlight, it becomes further dark. In the same way, if they say there is a dark urine, the color of the urine was actually normal. After some time, it became dark, and the patient is having joint pain. Joint pain with dark urine. Joint pain with dark urine, then it is going to be alkaptonuria. Joint pain with dark urine, it is going to be alkaptonuria. And if they say muscle pain with dark urine, then it is going to be what? Then it is going to be McArdle. McArdle. So sometimes what happens is I don't know for what reason we have got a tendency that whenever we see dark urine, we jump to alkaptonuria. It should not be like this. We should see the associated finding. If they say dark urine with joint pain, it's alkaptonuria. With muscle pain, McArdle. Abdominal pain, increased blood pressure, acute intermittent porphyrias. Right? Okay. Now, can you tell me one antibiotic which leads to dark urine? Because we are discussing the color of the urine, let's complete the color of the urine itself here. If they say dark urine, with which antibiotic, which drug can lead to dark urine? Can you tell me that? Yes? Anthony, can you tell me that? Dark urine. Yes, it is imipenem. Imipenem can lead to dark urine. Can you tell me pink urine? Pink urine. Pink color urine is seen in which condition? Which drug can lead to pink color urine? Yes, it was desferoxamine. Can lead to pink color urine. Green color urine? Green color urine. Which drug can lead to green color urine? Yes, triamterene can lead to green color urine. So these are some of the color. Yes, orange color is rifampicin, pyridium that is there. But as far as biochemistry is concerned, these are the important things to be remembered. Alkaptonuria. Alkaptonuria is due to deficiency of which enzyme? It is due to deficiency of HGA oxidase. HG oxidase, homogenetic acid oxidase. HG oxidase. Alkaptonuria. And what is the treatment of alkaptonuria? The treatment of alkaptonuria, nitisinol, NTBC. Nitisinol. Yes. Yes. Okay. The next one. A 7-month-old infant is presenting to us. He's having jaundice. His failure to thrive. He's having cataract. He shows increased galactose level. Which enzyme deficiency is there? Which enzyme deficiency is there? What do you say? Is it the galactose 1-phosphate uryl transferase or galactokinase? See, basically what happens is when we have discussed the galactose metabolism, first let me make you understand what is the meaning, how the galactose metabolism occurs, and then we will come back to the answer. When it comes to galactose metabolism, it occurs like this. It occurs like this. When the mother is going to breastfeed the child, the lactose molecules are there. This lactose molecule goes in the intestine because lactose is a disaccharide and we can't absorb the disaccharide. We require the monosaccharides. So we break the disaccharide lactose into the monosaccharide glucose and galactose with the help of enzyme lactase. And the glucose and galactose will get absorbed. The glucose and galactose, right now we are concerned with the galactose. So I'm just talking about galactose. This galactose molecule will reach all the way to the liver, and then the further galactose metabolism occurs. The first enzyme to metabolize is galactokinase, and then we have the galactose 1-phosphate uryl transferase that will further metabolize it. But by chance, if there is deficiency of this enzyme, then the metabolism will not happen. The galactose will increase. The galactose 1-phosphate that is going to increase. This galactose 1-phosphate can't come out. And because it can't come out, the phosphate will be trapped and it is not getting used. The phosphate is getting trapped. So this patient, because the phosphate is getting trapped, the phosphate deficiency will happen. And the second thing that happens is this galactose, which is increasing, it will come out here. It's going to come out here. And this galactose can convert into calcititol. And this calcititol can deposit in the eye that will lead to oil drop cataracts. Oil drop cataract. This galactose increases the risk of E. coli infection if there is more galactose. Plus, because this galactose 1-phosphate accumulated in the liver, slowly the liver will be big and it will be damaged. So the patient is going to develop the icterus. There's going to be jaundice. So this is what they are writing in the MCQ. What they are saying is, look at here now. There is a child, he's having hepatomegaly, cataract, jaundice, failure to thrive, more galactose. It's a classical galactosemia, and it is due to deficiency of galactose 1 phosphate uridyl transferase, GALT. It's due to deficiency of GALT. Now, here, let me tell you four very important disease. Very important disease. If they say breastfeed followed by vomiting, breastfeed followed by vomiting, then you have to see that whether they are mentioning jaundice or not mentioning the jaundice. If they say jaundice is there, then they are talking about galactosemia. Galactosemia, and that is due to deficiency of GALT. Galactose 1 phosphate uridyl transferase. Can you tell me that if I say breastfeed followed by vomiting, there is no jaundice? Can you tell me what will the diagnosis? Can you tell me a diagnosis from the surgical, so your knowledge of surgery, breastfeed followed by vomiting, no jaundice. Whenever the child is getting the breastfeed, he's vomiting. Male child, 1 month of age, what will the answer? What will the answer? Yes, it is hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis. Breastfeed followed by vomiting. If they say the milk products, when the child is consuming the milk products, he is having abdominal cramp. Milk products are leading to abdominal cramp, and the age will be somewhere around 8, 10, 15 years. This will be a newborn. Galactosemia is going to be a newborn, but here it's going to be 8, 10-year-old boy. Milk product leading to abdominal cramp, that is called as the lactose intolerance. This is going to be lactose intolerance. Right? If they say fructose, means the fruits are creating the problem. When the patient is eating the fruits, having the problem, he's having abdominal pains, fructose is creating the problem. It is fructose intolerance, hereditary fructose intolerance. Hereditary fructose intolerance. And do you know how we have remembered what was the mnemonic we have discussed? Fab gut. Fab gut. Fructose intolerance is due to deficiency of what? Aldolase B. Fructose intolerance, deficiency of aldolase B. Galactosemia is due to deficiency of uridyl transferase. Uridyl transferase. Fructose intolerance, it is due to deficiency of aldolase B. Galactosemia, it is due to deficiency of what? Uridyl transferase. Uridyl transferase. So these are the important diseases which are very similar, and the examiner always try to confuse in between them. Okay. The next is, and this we have already discussed actually, a patient is presented with severe combined immunodeficiency, and there is accumulation of deoxyadenosine. I told you already when I have discussed the purine catabolism pathway. Severe combined immunodeficiency, it is due to deficiency of what? It is due to deficiency of adenosine deaminase. And why it is called as combined immunodeficiency? Because which cells are affected? T and B both are affected. T and B both are affected. Yes, rightly said, Chandran. It's T and B both are affected. Yes, here we have discussed the purine catabolism pathway. Do you remember? Adenosine deaminase was here. If this adenosine deaminase enzyme is not there, this metabolism will not happen, and deoxyadenosine molecules are going to accumulate in the body. That is called as the severe combined immunodeficiency. Severe combined immunodeficiency. The next, a neonate is having the intellectual disability, seizures, and musty odor that is due to phenylketonuria. Which supplement of the following is indicated in the patient? What you want to give him in the diet that is going to help this child? The diagnosis they have already given. What you want to give? You want to give tyrosine, phenylalanine, dihydrofolate, or tetrahydrobiopterin. What is going to help him? Yes, can you tell me what you are going to give him that is going to help this child? Right? So here, see, let's understand how the phenylalanine metabolism occurs. The phenylalanine normally converts into tyrosine with the help of enzyme phenylalanine hydroxylase. And we require one more molecule to do this reaction, that is BH4, that converts into BH2. So actually there are two things which is required to convert the phenylalanine into tyrosine. And this is how we metabolize the phenylalanine. And because we want to reuse the BH2, so we convert the BH2 into BH4 with the help of enzyme BH2 reductase. reductase. But right now, to convert the phenylalanine to tyrosine, we require the hydroxylase and BH4. But by chance, if there is deficiency of any of them, this reaction will not happen. By chance, if this reaction will not happen, the phenylalanine is going to increase. And this phenylalanine will convert into its ketone version. And the ketone version of the phenylalanine is phenyl pyruvate, phenyl acetate, phenyl lactate, and these molecules will start coming in the urine. And that is called as phenylketonuria because the ketone version of phenylalanine is coming in the urine. Particularly, the one that is having the mousy smell is the phenyl acetate. So they give the MCQ like this, that there is a child, the mother is saying that whenever the mother is changing the diaper, very bad smell is coming from the diaper, very bad smell. They don't use the word mousy or musty, they say bad smell. The bad smell in the urine, it's phenylketonuria, phenylketonuria. And how we are going to treat it? There are several methods. First, try not to give phenylalanine in the diet. Because if the child will not eat phenylalanine, it will not convert into ketones, right? Because this phenylalanine is coming from where? It is actually coming from the diet. So we tell the patient, we tell the mother actually that don't give phenylalanine to your child. Phenylalanine free diet. Second, because it's unable to convert it, if we want to make it happen, what we can do is we can give the supplement of BH4. So at least some molecules will convert. So we give more BH4, more BH4. So this is what they're asking. How we are going to treat the phenylketonuria? What you are going to give more? We are going to give more BH4. We are going to give more BH4. Which of the following is indicated in this patient? How we are going to treat? Now, you may say that we should give the tyrosine also. We should give the tyrosine also. Yes, the tyrosine is going to be a supplemented, but the idea is what they are saying is in the phenylketonuria, basically the phenylalanine is unable to convert into tyrosine. But it's not that key, not even a single molecule will be converted, right? So there are two answers that could have been in this choice, but since means you could have given the answer of tyrosine or you could have given BH4, but the better answer will be BH4 because if you give BH4, in that case, you are actually treating the disease. You are treating the disease. But if you give tyrosine, that is just going, what we are doing is just trying to control the symptom because normally the phenylalanine converts into tyrosine and in this patient it is not happening nicely, so you are supplementing the tyrosine. That is fine, that is fine, that is to be done. But if you give BH4, if you supplement that also, then you don't have to even supplement the tyrosine. That is going to take care of everything. The phenylalanine what the child is eating in the diet, that will be also taken care, and the tyrosine will also be generated. So the better answer is going to be the BH4, the BH4, right? Yes, it was a tricky question because the tyrosine was also given in the choice. So what is supplemented? We will give tyrosine, we'll give BH4, but the better answer is going to be BH4. A patient is presented with poorly controlled diabetes and he's having cataract. And this is due to accumulation of sorbitol in the lens. It is due to following which of the following enzyme activities? Which enzyme is leading to this problem? See, what happens is in the patient of diabetes, let's say here is the representation of the blood. The glucose molecules which we are having, they can club with the hydroxyl group. And when they club with the hydroxyl group, the name of the enzyme is aldose reductase. And they make a molecule called as sorbitol. The sorbitol can go to the eye, can deposit in the eye, and can lead to snowflake cataract. So why in the diabetes the snowflake cataract developed? Because of which enzyme activity? It was the aldose reductase. It is the overactivity of the aldose reductase that is creating this problem. Because what is accumulating in the eye is sorbitol, and that was made by aldose reductase. Now you answer me the question that you give me the answer that which drug can be given if a patient is a diabetic and I don't want that he develops snowflake cataract, means I have to block this enzyme. Can you give me a drug which blocks the aldose reductase so that I can prevent the snowflake cataract? Aldose reductase inhibitor. Aldose reductase inhibitor. What you are going to give? Can you tell me what is the aldose reductase inhibitor we have to prevent the diabetic retinopathy or the diabetic snowflake cataract? Yes, it is epalristate. Epalristate is going to be aldose reductase inhibitor. If you give this, the sorbitol will not be made and the snowflake cataract will not occur, right? Okay, it's very good. Very good, Anuj. Let's move forward. A patient is presented with progressive muscle weakness. This muscle problem is happening. When the biopsy was done, there was lipid accumulation was there within the skeletal muscle cell. In the skeletal muscle, the lipid is getting accumulated. What we can understand from this word is basically why the lipid will get accumulated. Actually, when we break the lipid, we generate the fatty acids and the cholesterol mostly. And when we further break down that, that is the beta oxidation that is going to happen, and we are going to generate the ATPs, means the energy. But by chance, if this process is not happening, if the, for example, there is a problem in the beta oxidation part, if the oxidation will not happen, the fatty acids, the lipid, they are going to accumulate in the muscle. And this is what they are saying, that the fat molecules are there, the lipid molecules are there, means the fat burning is not happening. Now, what are the various enzymes that is there in the beta oxidation? Look at here, what are the enzymes which are here? Yes, these are the enzymes. How we do is the fatty acid first converts into acyl CoA with the help of enzyme acyl CoA synthetase. Then this acyl CoA enters inside the mitochondria with the help of a molecule called as CAT. And then this acyl CoA will further undergo breakdown, that is called as beta oxidation, and that provides the energy. But sometimes this CAT is not working actually. This CAT is not working. See how this CAT is transferring the fatty acid inside the mitochondria. Look at here. I want to transport the acyl CoA inside the mitochondria. So on the mitochondria, there are two surfaces, the outer and the inner. On the outer surface, we have the CAT1 enzyme, carnitine acyl transferase 1. That what it will do is the carnitine and acyl CoA will unite together and will make molecule called as carnitine acyl CoA. With the help of this carnitine acyl translocase, the carnitine acyl CoA complex will come inside, and then we have the CAT2 that is going to separate them apart. It's going to separate them apart, the carnitine acyl CoA, and then the acyl CoA can undergo beta oxidation. So this is how we are bringing the fatty acid. Basically, what is this acyl CoA? It's activated fatty acid, and this is how we are bringing the fatty acid in the mitochondria, and we are burning it. But by chance, if this enzyme is not there, that is the carnitine acyl transferase 1, the fatty acid can't come. And if the name of fatty acid is palmitic acid, if the name of fatty acid is palmitic acid, to bring the palmitic acid, which CAT1 you will use? That is carnitine palmitoyl transferase 1. Carnitine palmitoyl transferase 1. So if that is not there, the palmitic acid can't come inside the mitochondria and can't be utilized, so that will accumulate. So this is what they're asking. Yes, the answer is going to be carnitine palmitoyl transferase 1. There is deficiency of the CAT1 because the most common fatty acid that we are burning is palmitic acid. So it's carnitine palmitoyl transferase 1. Right? Very good. The next is a patient is presented with hemolysis. There is hemolysis happening after consuming the fava beans. What would be the expected in this patient? What is expected in this patient? See, when you eat the fava beans are going to produce a lot of free radicals. When you and me, when we are eating fava beans, nothing happens because on the RBC we have a cover that is called as the reduced glutathione. Do you remember? We always have this reduced glutathione that is a cover on the RBC. Whenever we have the oxidized glutathione, we immediately actually convert that into reduce. And to convert the oxidized into reduce, we require these hydrogens. And from where these hydrogen comes from? The NADPH. From the NADPH. And NADPH comes from which pathway? HMP shunt. What is the rate-limiting enzyme? The glucose 6-phosphate dehydrogenase. By chance, if there is deficiency of glucose 6-phosphate dehydrogenase that you discuss in the pathology as G6PD, if there is deficiency of this, the NADPH will not be produced. If there is no NADPH, no hydrogen, this reaction will not happen. The oxidized glutathione cannot convert into reduced one, means the shield on the RBC will not work. So when you are going to eat the fava beans, that is going to generate the free radicals and that can damage the RBC, that can lead to hemolysis. And this hemolysis will look like the Heinz bodies. The free radicals are going to precipitate the hemoglobin, that is going to be the Heinz bodies. And this defective RBC, when reaches in the spleen, the macrophage will eat out this defective part, and now the RBC looks like this. This is called as the bite cell. So we have lost some hemoglobin in that process, and that is a hemolytic anemia. This is called as the G6PD deficiency anemia. So if there is a G6PD deficiency, what molecule is not there? NADPH. And that is creating the problem. So they're asking this question, which of the following finding would be expected? There is decreased level of what? There is decreased level of NADPH because there is the diagnosis is G6PD deficiency. Can you tell me that what is the inheritance pattern? What is the inheritance pattern? It is X-linked recessive. X-linked recessive. X-linked recessive. Right? The next is a patient is presented with lactic acidosis, seizures, and developmental delay. Lactic acidosis, seizures, and developmental delay. A laboratory analysis sees that there is elevated levels of alanine. The alanine is more. Alanine is more. Which enzyme deficiency will be there? Now, it looks little tricky question, but what you can anticipate is the seizure is happening. One of the seizure that can happen in a child is because of hypoglycemia. That is one of the common metabolic causes. If you talk about the metabolic cause, one of the important is the glucose deficiency. Now, how all these related? Let's understand it here. See, when it comes to alanine, alanine is the most glucogenic. I think that out of all 20 questions, this was the most tricky question. The alanine, it converts into, if because it's the most glucogenic enzyme, it's the most glucogenic amino acid, sorry. So alanine, if I want to make glucose, how I can do is alanine first converts into pyruvate. Converts into pyruvate. And then this pyruvate can convert into glucose. This is how the gluconeogenesis happens from the alanine. Alanine converts into pyruvate with the help of the enzyme transaminase. If you remember the mnemonic that I told you, so LP, L stands for alanine, P stands for pyruvate. Alanine converts into pyruvate, pyruvate converts into glucose, and this is called as the gluconeogenesis. Now, when the pyruvate converts into glucose, first the pyruvate is supposed to convert into oxaloacetate. And to convert the pyruvate into oxaloacetate, pyruvate is 3 carbon, oxaloacetate is 4 carbon. What will the name of enzyme? Pyruvate carboxylase. So in the gluconeogenesis, you require pyruvate carboxylase. Now you answer me the question. The pyruvate carboxylase is here. You answer me the question. If this enzyme is not there, the gluconeogenesis will not happen. And what happens with the glucose level? Less. And because this reaction is not happening, the pyruvate will increase. And because the pyruvate is increasing, the pyruvate can convert into lactic acid. Because there is more pyruvate, it can convert into more lactic acid. So you can see hypoglycemia is happening and there is more lactic acid. And because this reaction is not happening, the alanine will also more. There is more alanine, more lactic acid, and less glucose. So actually, this question was little tricky, but one of the hint that was there was seizure. When the seizure comes, the first thing is glucose is less. That could have been like this, and then we can connect with the alanine. Alanine is the most glucogenic. From how we make the glucose from alanine to glucose, then you could have think of the pathway, and then you can set with the enzyme. If you were not able to do that, you could have gone by the options. If there is pyruvate dehydrogenase deficiency is there, pyruvate dehydrogenase deficiency is there, that is not related to alanine at all. There is lactic acidosis happens. See, answer is this one. Answer this one. I am saying why dehydrogenase is not there. In this, we will have lactic acidosis, plus we will have the seizures, means hypoglycemia. But alanine levels are not increased. Alanine levels are not increased. Alanine is not increased. In the lactate dehydrogenase deficiency, again, it is nothing to do with the alanine. So that is not the answer. And if there is alanine aminotransferase deficiency, which is the enzyme actually here, if this reaction is not happening, alanine will increase, but the pyruvate or the lactic acid will not increase. So this cannot be the answer again. So we are left with only one answer. You could have gone retro and you could have find out that how it is linking with the things, right? It was little tricky. Last question, easy one. A child is diagnosed with phenylketonuria because development delay, blue eyes, fair skin. What is the biochemical basis of this disorder? What is the biochemical? Actually, we have already discussed. That is just a repeat for us. What happens in phenylketonuria? The phenylalanine is unable to convert into tyrosine. because either there is deficiency of this or deficiency of BH2 reductase. If there is deficiency of this is called as PKU type 1 and this is called as PKU type 2, phenylketonuria type 2. So now, if they're asking what is the biochemical, is it deficiency of phenylalanine? No, it's not deficiency. It's unable to convert the phenylalanine to tyrosine? Yes. Is it excessive tyrosine? No, tyrosine is less. Is it defective phenylalanine transport? No, right? It's the phenylalanine to tyrosine, it's not happening. Can you tell me what is the investigation of choice of phenylketonuria? Can you tell me what is the investigation of choice? Yes, it is going to be the tandem mass spectrometry. Tandem mass spectrometry is the investigation of choice. What is the other test that you can do in phenylketonuria? It is Guthrie test. We can do Guthrie test also, right? But in investigation choice, tandem mass. Tandem investigation choice is tandem mass, right? So this is all from the biochemistry part. Hope you have learned some concepts here, and it is going to be very helpful for you in the exam. Whenever you are stuck, try to think when they are trying to confuse with different enzymes. Try to think retrospectively and put that the things in the perspective. That whether if this enzyme deficiency is there, whether all the things are matching up with the questions or not. So that way, sometime we might get an answer. And that was there in the question number 19, right? Some of the questions were directly straightforward, but actually, I have deliberately put like this because in every exam there are all the types of questions are there, right? Easy, difficult, everything's are there. Plus, the main important agenda was to make you understand how to approach MCQ. What are the important things that is there around that topic? We have tried to cover in these 20 topics in this small session of almost 1 hour 20 minutes. Right? Wish you all the very best. And we are just 1 month away from the INCT, and these last 30 days, last 30, 40 days in any exam, it's going to be very crucial. Right? So let's work very hard and wish you all the very best. Wish you all the very best. Thank you.